The Knowledgeable Provider podcast is intended primarily to entertain, also to inform, but it is not a substitute for actual medical training and should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, please make an appointment to see your own knowledgeable medical provider. The opinions expressed by me and anyone else who happens to appear on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than the lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. Look, this is all for fun, okay? Don't sue me. All right, on with the show. Hey there, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. I have some exciting news from Patreon. Y'all, we have doubled the number of Patreon supporters. The number of Patreon supporters has increased by 100%. We now have 2 Patreon supporters. And in all seriousness, thank you to both of you. You know, it's not so much about money, but it is nice to know that someone appreciates what I'm doing enough to actually pay me for it. That really makes me feel good, and it really motivates me to keep doing this. You know, it's one thing to know that people are listening. It's another thing entirely to know that people are paying for what you're putting out there. It's a very strong motivator to keep going and keep making more content. So thank you both. Very much appreciated. If you would like to be a Patreon supporter, check out patreon.com/knowledgeableprovider. And as a special thank you to anyone who signs up, you'll get access to our new private Discord server. If you're not familiar with Discord, it's more or less a chat room. I've invited all of the previous guests on the podcast as well as Patreon supporters. And I just sort of keep it open on my computer at the office during the day. And if I see something interesting, I'll drop in there and put a comment, or if someone asks a question, I'll try to answer it. Had a really nice conversation going with my cousin David, who was the star of our episode on ARFID. So it's a neat way to connect. It's a neat way to start building a little community of Knowledgeable Provider guests and fans. So if you're interested, head over to Patreon and check it out. It's $5 a month, and it really means a lot. For today's episode, I actually want to respond to a couple of requests I've received from listeners and Patreon supporters. Coincidentally, both of them involved the previous episode on prostate cancer, which is episode number 19 in season 1. One listener let me know that they would be more interested in knowing some more details about the screening for prostate cancer and how I feel about that. And another listener who's a patient came into the office. It always shocks me when somebody's like, I love your podcast, because it almost never happens, but it's neat to know that patients are listening too. But this patient asked about a patient that I mentioned in the prostate cancer episode, and it took me a week to figure out who it was, but they were asking for an update, so I'll start there. The patient I mentioned was a younger guy in his 40s that came in to establish care with me, and basically a very healthy guy. But recently at work, he had done a little medical screening, and they told him that his ferritin level is very high. And so that's kind of what led him to come in and get established with somebody. So I told him it's probably no big deal. We rechecked it, and sure enough, ferritin's very, very high, like 900. So where I left off in the previous prostate cancer episode, we were sending him to hematology to let them figure out what was going on. So here's the update. Hematology evaluated him and diagnosed him with hereditary hemochromatosis with iron overload syndrome. They sent him for an MRI of his liver, and sure enough, they could see a bunch of iron deposits in the liver. The plan was to treat him with regular phlebotomy, and he's taking a testosterone supplement, which of course tends to increase production of red blood cells. And just from reading their note, I don't think they outright told him to stop taking it, but you could tell that they sort of would prefer that he not take it in the interest of not making the blood any quote-unquote thicker than it already is. So I don't know if he's going to stop that or not. And another thing that came out in the hematologist note is that he has some kind of allergy to poultry, and so he mostly only eats red meat. So that's another source of a lot of iron in his diet. The patient who asked me about this actually was speculating that he might have been doing a carnivore-only diet kind of thing, and that was the reason for the excess ferritin, which is a great thought. And it turned out maybe that was contributory. So thank you for asking. I had forgotten all about it, to be honest with you. I'm always trying to stay alert for interesting things to talk about on the podcast or updates of things I've talked about in the past. But to be quite honest, I probably don't remember most of the patients that I have mentioned on the podcast or situations that I've mentioned. So if you have a question about one, feel free to get in touch anytime. Now on to the prostate cancer screening question. The history of prostate cancer screening and how the guidelines have evolved over the years is a really interesting story. I guess patients generally understand that guidance and research and science changes over time. I don't know if people realize just how fast things progress. If you're looking at one particular issue in medicine, if you're waiting for a cure for some particular cancer, I'm sure it can seem like medicine moves at a glacial pace. But for someone like me who's just trying to keep up with as much as I possibly can, it seems like trying to drink out of a fire hose, right? Things change all the time. I started in my current role back in 2018, so this will be year 6. And when I first started with Dr. James, I made myself this huge cache of documents that I called clinical cheat sheets. And it's just basically a huge outline of all the different things that I was going to see and all the pertinent guidelines. And I asked Dr. James to review it and tell me, like, okay, what do you want me to do in this situation? What do you want me to do for this? What do you want me to do for this? And so it was basically just a huge quick reference document that I could look back at if I wasn't sure about what to do in a situation. And of course, the longer I worked, the less I had to refer back to it. And now I actually rarely look at it anymore. For a while, I was giving it out to students who would come do their rotations with me just as hopefully a helpful summary that they might be able to use to study and learn. But looking back at it now, it's all so out of date. I quit giving it out a couple of years ago because I would have to go back and totally update the whole thing. It is pretty remarkable how quickly things change in medicine. And so I'm sure it can feel odd for a patient seeing things change over time. Like you go to your appointment one year and do XYZ, and then maybe the next year you come and you're not doing XYZ anymore. You're doing ABC. A particular thing that used to be done is not done anymore, even if that's something that you are used to having done, even for the past 20, 30, 40 years, however long it's been. Now we're changing. So I'm sure it can be a little disorienting and maybe even unsettling for patients. So here's a little history and timeline of prostate cancer screening and how recommendations have changed, how all this came about, and how the current state of affairs came about. According to this article from the International Journal of Urology by Kazuto et al. From June of 2019, the first actual recommendation for doing digital rectal exams for older men was in the early 70s, 1971, in Germany. 4 years later, there was a study in Japan that studied using transrectal ultrasound to examine the prostate. In 1976, the first study specifically looking at using transrectal ultrasound for prostate cancer screening was done in Japan. In 1981, another Japanese study looked at using a serum marker called PAP, which stands for prostatic acid phosphatase, which would be super confusing since people with cervixes go get PAP smears. So that study looked at using that particular marker along with digital rectal exam in men 60 years of age or older. PSA, prostate-specific antigen that we're all familiar with now, came about in the late 80s. This is from an article by Albertsen in JAMA Network Open from 2019 also. It says there was a report by Stamey et al. In 1987 that showed that the PSA level correlated with prostate cancer. 4 years later, another study by Catalona et al. Showed a pretty strong correlation with elevated PSA level and prostate cancer detected with prostate biopsy. So the early 90s is when widespread screening with PSA kind of started in the United States. The PSA test was actually approved by the FDA in 1994. Another couple of developments that happened around the same time were a better transrectal ultrasound probe and a spring-loaded needle designed for prostate biopsies, which allowed those things to be done in an office setting. So the whole process suddenly just got a lot easier, right? You think about having to do a digital rectal exam, see if you find something, then the patient has to go to a urologist, then into the hospital to have any further testing done. Well, now with the advent of PSA and these other new technologies, we can very easily check the PSA. Then you go over to the urologist's office, have your ultrasound and your biopsy done right there in the office. So after that, it was off to the races. And it turned out that the PSA was really, really good at detecting prostate cancer compared to just shoving your finger up there and seeing if you feel anything. I'll say a few words about the digital rectal exam, or DRE. That really is what it boils down to. You're literally just feeling the top of the prostate, or I should say the superior aspect of the prostate, and you're feeling for any kind of abnormalities. The prostate's this little sort of walnut-sized kind of gland normally, and they teach us in school that it should feel about like the thenar eminence of your hand. So if you look at the palm of your hand, at the base of your thumb, there's this kind of mound of muscle tissue right there. That's sort of what the prostate ought to feel like if you kind of tighten that up. If there's a tumor in there, sometimes you can feel it. Sometimes it turns into this jagged kind of mountain inside the prostate. Or, of course, the prostate can be enlarged, or you can notice that it's asymmetrical. As you might imagine, it's not the most reliable way to find something. Just like any other physical examination, you kind of have to feel a lot of normal prostates before you know what that's supposed to feel like and would be comfortable recognizing something that's abnormal. I was fortunate in part of my training to get to learn both the genital and rectal exams from a live model. There was a gentleman who came into the school, and if I recall correctly, he was wearing a robe, which I thought was funny. But we all sat around this. It was like a small group of students, and we sat around this conference room. He's wearing his robe, clothed, sort of. And he gives this presentation about, okay, here's how the genital exam works, and here's how the rectal exam works. And I think he had some little flashcards or, like a notebook with a paper presentation in it. He had some kind of visual aid. And then at some point he was like, okay, he stands up, throws open the robe, and he's like, come on, practice. And then one by one, every student got to try it out on this man's body. Definitely much appreciated. Definitely have a lot of respect for anybody who would do that. And also, I hope they get paid a whole lot of money for letting a bunch of inexperienced people handle their junk and probe their rectum. There were also female instructors, or whatever you call them, models, who came in and did the same thing for the pelvic exam and breast exam. Mad respect for all of you medical teachers / models out there. Thank you for your service. The other time I was trained on a prostate exam was in the lab down at South Alabama, and they had this little model of a butt. So the examiner would stand on, the business end of the butt and simulate performing the exam. And then somebody else on the other side had several different prostates that were interchangeable. They could put a different prostate in the little simulator. And so your job as the examiner was to put your finger in there and try to feel for whichever abnormality the other person had put in there with the fake prostate. So that's about the extent of the training I got as far as doing prostate exams. So that's just kind of a long way of saying it's really not a very reliable exam. If you're a urologist and you've done 17 million prostate exams, yeah, absolutely, it probably is reliable. For somebody like me who had done a couple, maybe by the time I got out of school, and has just kind of been doing them here and there in the office setting, would I recognize it if it was abnormal? Maybe, maybe not. It'd have to be pretty freaking abnormal before I would recognize it, I would think. And then you throw in just the awkwardness of the exam, which I promise as medical people, it's not as awkward for us as it is for patients. It's just looking at a part of the body, feeling a part of the body. I don't really think anything about it. Same thing with genital exams, breast exams, any kind of sensitive physical exam. I don't really have any qualms about doing it, but I know the patients are uncomfortable, and that makes me uncomfortable. It's just sort of an awkward situation, right? And you don't want to do anything to hurt the patient. You don't want to mess up. You don't want to do anything that would seem or feel inappropriate. So it's just not a great situation all the way around. And then two, if you think about it, you're really only feeling one aspect of the prostate. So it's a sphere, more or less, and you're kind of just feeling one side of it or one wall of it. So you could certainly have a tumor that's down in there that you can't feel. It's this old joke in medicine about what's the only reason not to perform a rectal exam on a patient? Either the patient doesn't have a rectum or you don't have a finger. Oh, I'm picturing the old guys on the Muppet Show up in the balcony laughing. Oh, but really and truly, it's probably not that great. So I can definitely see how if you were a practicing clinician in the period of the 70s, 80s, 90s, if you've been doing rectal exams for 20 years and now all of a sudden there's this blood test you can do that is better for detecting prostate cancer, of course you would jump on that. Of course you would go, yay, no more rectal exams. Let's just do this blood test instead. And I would assume that most patients would prefer that as well. So that's what happened. Everybody started doing PSAs, and the diagnosis of prostate cancer went through the roof. If you look at a graph of the incidence of prostate cancer, it's kind of this sort of gradually sloped line up into the mid-90s, and then it goes boom, straight up through the roof, like from 100,000 up to 350,000 just in the course of a couple of years. So wham, all of a sudden we're finding all this prostate cancer, which means that all these people now are going to get treated for prostate cancer. They're getting their prostates radiated or taken out, which sounds like it would be a good thing, except we know that a lot of prostate cancer is really not that life-threatening. A lot of prostate tumors are very slow growing. A lot of prostate cancer, if it was not detected, would never even really cause a problem. We learn you're more likely to die with prostate cancer than die of prostate cancer. Not to say that people don't die from prostate cancer, of course, and there's some different grading and classification and calculation tools that are used to kind of figure out, is this a high grade, high risk kind of cancer or is it not? So I don't mean to minimize the experience of anyone who has had prostate cancer or who knows somebody who's died of prostate cancer. Obviously, it's a big deal. However, the result of the PSA test coming along is that we started finding a lot more of them really would have ever caused a problem. There's a similar story with kidney cancer. With the advent of CTs and MRIs and all this imaging, we start finding all these incidental renal tumors. And it's sort of the same deal. Like, would that have ever caused a problem? We don't know, but now we got to do something about it. And so kidney tumors, you're seeing this huge increase in the diagnosis and treatment of kidney cancer, but the mortality rate from kidney cancer is not really changing because we're treating a lot more of them than would have ever killed anybody. And so it's the same situation with prostate. And it's kind of easy to put yourself in that situation, right? If I'm going in to get my screening test and my PSA comes back high and I go get a biopsy or I go get an ultrasound, or actually now these days, if I go get a prostate MRI and there's cancer in there, it's going to be a pretty hard sell for me not to want that cancer out of my body. And in my experience, that is how most men tend to feel about it. Like, oh, there's cancer, get it out. You said the C word, get it out. We want it gone. We want it gone. I do have maybe one or two patients who have known prostate cancer and have chosen to just watch it because it is at very low risk of spreading or causing a problem. But for the most part, I think once it's found, most people are going to opt to have it treated. And treatment of prostate cancer is not a benign prospect. Once they start messing with the prostate, and especially when they remove the prostate, it causes a lot of problems. A lot of people, once they have their prostate removed, develop incontinence that really cannot be modified with drugs or anything else. There are some little procedures and devices that can be done to correct it, but very common to have urinary incontinence after that, and very, very common to have erectile dysfunction. And not the kind of erectile dysfunction where you can have some Viagra on the bedside table and that makes it all better. The kind that, like, it doesn't work anymore, period. You can go get yourself a surgical implant or you can give up. And of course, any kind of invasive procedure like taking a prostate out is going to come with risks of infection or other complications. You have to go under general anesthesia, and that's not without risk. So in this case, the pendulum kind of swung too far the other way. We got real good at picking up prostate cancer, but it turns out that the outcome of that was really not that great. According to this JAMA article, more than half of the cancers identified by PSA testing are ones that would not really require any sort of treatment, that would not cause a problem. So that's a lot. So as far as how the recommendations for screening have changed, by 2008, the U.S. Preventive Services Task Force, USPSTF, came out and said, we do not recommend PSA screening for men 75 and older, and we're not sure about the benefits and harms of screening for younger men. 2012, they updated their recommendation and said, we recommend against PSA screening for all men, period. There's not enough evidence of benefit, and there are so many potential harms that we just recommend against this completely, period, end. 2017, they reverse themselves. They say, okay, for men age 55 to 69, we recommend individual decision-making about whether they want to be screened or not. They are looking at that guidance again now. It seems like probably they're going to revise their guidance on this fairly soon. As far as other agencies, the American Cancer Society's current recommendation is to start offering prostate cancer screening at age 50 for men who are at average risk and who are expected to live at least 10 more years, age 45 for men at high risk, and age 40 for men at very high risk. That means more than one first-degree relative who had prostate cancer at any age. They recommend using the PSA, and they say the digital rectal exam may also be done as part of screening. Assuming there's no cancer found, they recommend repeating the PSA every 2 years for men whose PSA level is less than 2.5, or annually for men whose PSA level is greater than 2.5. They don't recommend screening anybody who has less than a 10-year life expectancy, regardless of age. The American Urological Association recommends beginning screening between age 45 and 50 using the PSA, or beginning at age 40 for people at higher risk. They recommend offering screening every 2 to 4 years for people age 50 to 69. Again, they say that clinicians may use the digital rectal exam along with the PSA. In our practice, we pretty much start at 45 for everybody, unless, of course, there's some reason that they're at higher risk. And typically, we just do the PSA once a year, unless somebody does not want that. And just in my limited experience, it is pretty reliable. If you see that PSA start trending up all of a sudden, chances are they have prostate cancer. I should point out also that it is certainly possible to have prostate cancer without the PSA going up. We have 1 or 2 patients in the practice that has happened to. As far as rectal exams, I generally only do those if there is some real reason to. So like if a patient is having some symptoms suggestive of a prostate issue, or if somebody requests it. Every once in a while, we'll have a guy come in that just prefers to have the prostate examined, which is fine. And then if I have a concern about something, whether it's the PSA rising or some abnormal finding on an exam, then I send the patient to urology and let them decide what to do. So that's where we are on that currently in the United States and in my practice. I hope that answers your question. If you ever have a question for me, whether it's about something I've talked about in a previous episode, or if you'd like to suggest an idea for future episodes, please always feel free to get in touch. Thanks for listening. I hope you have a great week, and I'll see you next time on Knowledgeable Provider. All right, that does it for this episode of Knowledgeable Provider. I'm your host, Jody Marks. Thank you so much for listening. Please be sure to like, subscribe, or follow on your preferred listening platform. Give us a nice 5-star rating and leave a nice review. If you'd like to help support the show, you can do that at patreon.com/knowledgeableprovider. And as always, stay safe, take care of yourself, and take care of your patients in that order.